Lesions can theoretically occur anywhere in the brain. The size and site of the lesion will determine the types of symptoms one will see. For step 1, there are a number of brain lesions you're expected to know, so you should make some time to review the chart in your book. But the main thing to remember when going through these lesion syndromes is what is the area lesion responsible for normally, and then from there it's rather intuitive what the symptoms of that lesion would be. So let's start with the frontal lobe. Now this is responsible for most of the processes and behaviors we think of as cognition, right? So this includes things like language, memory, and judgment. While doing this, it also inhibits many of our more automatic behavioral programs that are generated in subcortical brain regions like the amygdala. Now, when this region is damaged, it leads to deficits in things like judgment, in things like concentration, and a number of different cognitive processes. And patients can often have different personalities, which is one of the more interesting effects of frontal lobe lesions. The next two lesions deal with the visual system. As far as your test, you should remember the way these lesions affect the direction that the eyes look. So let's start with the paramedium pontine reticular formation. Sometimes you'll see referred to as the PPRF. Damage to the PPRF, which is in the pons, will end up causing the eyes to look away from a lesion. If, on the other hand, you damage the frontal eye field, which is by the premotor cortex, you get the opposite result, and the eyes would look toward the lesion. The medial longitudinal fasciculus, or MLF, is a region that carries information that coordinates eye movement. It connects various cranial nerve centers to ensure that the various nerves that control different muscles necessary to coordinate the two eyes are working together to produce the wanted gaze. So, when it's damaged, it causes the following deficit, where in this example, the right MLF, right, so the right MLF is damaged, the eye on that side cannot adduct. So normally you can see that this right eye can move in this direction. This left eye can, in this case, adduct. However, here, while the left eye can move sort of outward or abduct, the right eye is not able to adduct. At the same time, you also see that the opposite eye has nystagmus. Now, this is called internuclear ophthalmoplegia, or INO. Whenever you think about or see the MLF being involved, there's an automatic connection that you should make. What is it? It's multiple sclerosis. The MLF is a typical site for lesions in MS, and INO is a symptom that can clue you into a MS diagnosis and is frequently tested in some way. If there's damage to the non-dominant parietal temporal lobe, you can end up with something called a spatial neglect syndrome. In this syndrome, the patient doesn't have an understanding that a contralateral side of the world exists. So one way that we can actually test this clinically is by asking them to draw a clock. And when you do that, you'll get something that looks like this. So all of the numbers will be, relatively on one side of the clock. There are a couple other tests that you can do, like ask them to reach and grab the other arm. It's really interesting when you see this in the clinic. However, if there's damage to the dominant parietal temporal cortex, then patients present with something known as Gerstmann syndrome. Now, this consists of deficiency in writing and understanding math, inability to recognize fingers, and left-right disorientation. The hippocampus, as you know, is critical for memory formation. So lesions to the hippocampus cause anterograde amnesia. Something important to remember about the hippocampus is that it is very sensitive to anoxic injury. So if a patient has been without blood flow for a while or is unable to breathe for some time and you are asked about a brain region that might be damaged, the hippocampus is worth thinking about. The basal ganglia, which involves the caudate, putamen, the subthalamic nucleus, and the globus pallidus, is involved in a number of different neurological conditions. It is generally involved in functions such as movement, motor control, and habit formation. Now, there are two diseases that should be at the top of your list if you are thinking about basal ganglia involvement. These are Parkinson's disease and Huntington's disease. Remember that though Parkinson's is usually associated with the substantia nigra in the brainstem, many of the symptoms are the result of decreased dopamine in the basal ganglia circuitry. Damage to the subthalamic nucleus is responsible for causing contralateral hemibolismus, and this is a very classical brain region. The Wernicke-Korsakoff syndrome involves bilateral lesions of the mammillary bodies. These happen usually in patients who abuse alcohol. The Wernicke aspect consists of confusion, ophthalmoplegia, and ataxia. This is a classic triad that you should know: confusion, ophthalmoplegia, and ataxia. This can then progress to Korsakoff, where you get memory loss, confabulation, as well as personality changes. Now, if you think back to your biochemistry, you remember that this syndrome occurs due to the lack of a particular vitamin. Do you remember which vitamin this is? Remember, thiamine or B1 deficiency is the cause of Wernicke-Korsakoff. Thiamine deficiency is typically seen in chronic alcoholics, and this is why there is the correlation between alcohol and Wernicke-Korsakoff. Kluver-Bucy syndrome is rather famous. This occurs when the amygdala is damaged bilaterally. Now, this results in hyperorality, hypersexuality, and disinhibited behavior. Think of this as the Friday night fraternity party on your college campus. One gets these symptoms because the amygdala is important for generating anxiety and fear. So you lesion the amygdala, broadly speaking, you get rid of these drives for fear and anxiety. And this is important for inhibiting some of those behaviors that we talked about. The dorsal midbrain contains a number of nuclei that are important for eye movement, including the superior colliculus and the Ettinger-Westphal nucleus. Now, damage to the dorsal midbrain, which is kind of what's indicated here, will result in Parinod syndrome. The key symptom here is vertical gaze palsy. And if you see a vignette where this is the symptom, you should be thinking about the dorsal midbrain. The reticular activating system is a set of nuclei in the midbrain that release cholinergic as well as noradrenergic neurotransmitters. This system regulates arousal and wakefulness, so it makes sense that a lesion in the reticular activating system would lead to reduced levels of arousal, right? So reticular activating system lesion, it leads to decrease in arousal. And one way this will often manifest is as a coma. The cerebellar hemispheres are thought to be important for planning and coordination of motor programs, as well as aiding in the processing of sensory information. So based on its role in planning motor action, what do you think is one of the primary deficits when it is damaged? Well, you can expect to see intention tremor. This tremor only begins when a patient is moving his limbs towards a target. You can see this with ataxia as well as difficulty with balance. The red nucleus, seen here, is another movement center. It is primarily responsible for directing movement in vertebrates without a corticospinal tract. However, in humans, it plays a secondary role. The red nucleus, seen here, is another movement center. It is primarily responsible for directing movement in vertebrates without a corticospinal tract. However, in humans, it does take a secondary role. It is important because lesions at or below the red nucleus results in decerebrate posturing. Now, this is where all the limbs are extended at rest, and it looks something like this. It has a very poor prognosis after brain injury. Lesions above the red nucleus result in decorticate positioning, which looks something like this with the muscles flexed instead of extended. The cerebellar vermis is also responsible for coordinating and fine-tuning movement. When it is damaged, you can see truncal ataxia and gait instability. Again, you should really take the time to know what the different brain regions do. This initial effort will make it very easy to figure out what different symptoms are telling you about which brain regions are likely to be involved.